Good evening and welcome everyone. Thank you for joining us today for this important webinar on newborn screening test. My name is Krishna and I am part of the marketing and product team at MedGenome Labs. I would like to express our gratitude for your participation today and your commitment to the health and well-being of our youngest member of society. Before we start, I would like to inform you that we will have dedicated time for questions at the end of the presentation, but please feel free to ask questions in the chat box through the presentation. We have a lot of exciting and informative content to be covered today. So without any further delay, I would like to welcome Dr. Venkat Swami. Dr. Venkat is an accomplished geneticist and lab director at MedGenome Labs, and he brings over a decade of leadership experience and cutting-edge genetic research for diagnostic applications. He received prestigious training at renowned institutes, including CMC and AIMS, New Delhi, and as well as in Nattera, California. Specializing in reproductive genomics, Dr. Venkat has honed his expertise in non-invasive prenatal testing, which is NIPT, pre-implantation genetic for aneuploidies, PGTA, and monogenic disorders, PGTM, alongside Sanger and PCR-based PGTM methodologies. With his extensive training and experience, he possesses the capability to autonomously oversee lab operations, ensuring strict adherence to both domestic and international standards. Notably, he upholds accreditation requirements such as CAP and NABL, showcasing his commitment to maintaining quality and regulatory compliance. Dr. Venkat hands-on experience spans a wide range of diagnostic techniques, including karyotyping, phase PCR, Sanger sequencing, Illumina, high-sec instrument, microarrays, next-generation sequencing, and various cytogenetic approaches. His training at esteemed institutes has contributed to his well-rounded expertise and comprehensive understanding of cutting-edge genomic technologies. As a lab director at MedGenome, Dr. Venkat's passion for advancing genetic research and his leadership skills drive the development of the state-of-the-art genomic diagnostics. His extensive training and experience gained from a prestigious institute both in India and California position him as a trusted leader in the field. Now with this, I would like to welcome Dr. Venkat to start the session as a moderator of this event.
Thank you, Mr. Krishna, for that warm welcome. Ladies and gentlemen, a warm welcome from my side too. I am deeply humbled and excited to moderate this important discussion on newborn screening. While my role was not originally planned, I am fully committed to ensuring that we have valuable and engaging session. Before we delve into the heart of our discussion, allow me to introduce our distinguished presenter for today. Our speaker today, Dr. Seema Thakur, is a pioneer in the field of genetics and fetal diagnosis. Her impressive credentials and remarkable contributions have left an indelible mark on the medical community. Currently holding the position of senior consultant at Fortis Hospital, Rainbow Children Hospital, and the Genetic Clinic, Dr. Thakur's academic qualifications include an MS in obstetrics and gynecology and a DM in medical genetics. She has a proven track record of leadership. Currently, she is the chairperson of AOGD Genetics and Fetal Medicine Subcommittee and Vice President of DGF Dwarka. Dr. Thakur's accomplishments are a testament to her dedication to excellence, including the title of Professor awarded by the Apollo Hospital Education and Research Foundation. She has been honored with the Distinguished Medical Luminary Award by IMA, Women's Doctor Association in Delhi in 2021, and the prestigious Dr. APJ Abdul Kalam Appreciation Award in 2022 by Delhi Gynecologist Forum. With over 2 decades of experience in genetic or genomic counseling and prenatal diagnosis, Dr. Thakur's expertise shines through her 62 publications, including contributions to esteemed journals like Nature Genetics and the American Journal of Medical Genetics. She has also been instrumental in organizing numerous continuous medical education CME programs, events focusing on fetal medicine and genetics, and serves as a valued reviewer for several peer-reviewed journals. It's an absolute privilege to have Dr. Seema Thakur as our presenter today. Please join me in giving her a warm virtual welcome. Welcome, madam. Thank you, Dr. Thakur, for joining us. We are eager to hear your insights on newborn screening. We'll start with Dr. Thakur's presentation and then move on to the QA session. With this, I hand it over to Dr. Thakur.
So, good evening, everyone. And today I'll be discussing about the newborn screening, which we all know is the need of our for the youngest population of our country. And I'll be discussing today a brief overview of inborn errors of metabolism, so as to make you understand the basic program, that is the newborn screening program, the disorders included in the newborn screening, the cases, and some algorithm for what is suitable for our country.
Madam, sorry to interrupt you. Can you put it in the presentation?
This is presenter view only, no?
A presenter view, but we are viewing the notes and other things. I think you have to select the other screen.
So should I end show and then restart?
Yes, ma'am.
Can you see my screen?
Yes, ma'am.
Yeah. So the term inborn errors of metabolism was first described by Sir Archibald Garrett in 1908. Inborn error of metabolism is caused by a block in a metabolic pathway due to the deficient activity of specific enzyme. So IEM, which are due to the impaired activity of the enzymes, transporters, or cofactors, they result in the substrate accumulation of the abnormal metabolites proximal to the block or lack of necessary products, and this will lead to the clinical manifestations. So they are, as a group, they are not rare. The incidence is about 1 in 1,000 births collectively, and which is similar to the Down syndrome, for which we do the prevention of Down syndrome to a significant extent. And many of them are treatable if diagnosed in time. So the most difficult task for a clinician is to know when to suspect the inborn IEM and which test to order for the evaluation. In NICUs catering to the sick babies in India, the incidence of IEM is as high as 74 per 1,000 babies is screened. So it is about 7%, so which is a very significant number. So it's high time that we need to understand when to suspect and what are the tests we need to order for to diagnose these inborn errors. So depending upon the presentation, the IEM, they are classified as group 1, group 2, and group 3 disorders. And this classification helps the clinician to understand the pathophysiological perspective. So in the group 1, which are intoxication disorder, where there is accumulation of the toxic metabolites. In the group 2, energy failure group, which is where there is a production of the energy or utilization of the lack of the energy. And group 3, these are the storage disorder, where there is a storage of macromolecules like LSDs. So the group 1, they would include amino acid disorders, organic acidemia, and urea cycle disorders, where there is an intoxication due to the accumulation of the metabolite. In the group 2, energy failure group, which include pyruvate dehydrogenase, fatty acid oxidation disorder, where there is a failure in the production of the energy, and the storage disorders, as the name suggests, that there is a storage of the metabolite, and they would include the lysosomal storage disorders, Zellweger syndrome, congenital disorder of glycosylation, to name a few. So how do they present? A common presentation of IEM is an apparently healthy child presenting acutely with a short history of illness and which is worsening progressively. And the symptoms could be as mild as a fever or as severe as an encephalopathy or status epilepticus. And the few common presentation are in the form of acute presentation, that is the recurrent episodes of vomiting, respiratory distress, ataxia, lethargy, or coma, with or without the seizures, hypotonia, hypoglycemia, or hyperammonemia. Then it could be in the form of chronic and progressive symptoms such as developmental delay, epilepsy, or other neurological illness. Or there could be organ-specific presentation such as hepatopathy, cardiomyopathy, neuromuscular, renal symptoms, gastroenterological symptoms, or hematological illnesses. Antenatally, they can present in the form of hydrops fetalis, like the most common is MPS 7 or the eye cell disease. Even the maternal HELP syndrome can be manifested if the fetus is having the acyl coenzyme dehydrogenase deficiency. In the congenital disorder of glycosylation, cerebellar hypoplasia can be noted on the antenatal ultrasound. Some of the disorders which are prone to develop as an encephalopathy would include altered sensorium like urea cycle disorders, maple syrup urine disease, propionic acidemia, methylmalonic acidemia, fatty acid oxidation defects, respiratory chain disorders, pyruvate carboxylase deficiency. So just to say that, they would present as a common illnesses only, just that we need to have high index of suspicion so that we can identify these disorders and do the further testing. They can present in the form of seizures like pyridoxine deficiency, then sulfite oxidase deficiency, molybdenum cofactor deficiency, non-ketotic hyperglycemia, or they could present in the form of hypoglycemia like fatty acid oxidation defects, GSD, that is the glycogen storage disorders, fructose 1,6 biphosphatase deficiency, or in the form of the liver failure like tyrosinemia. Many of the neonates who die in the neonatal period, they are referred to us with the features of the hepatic encephalopathy, and the disorders included in this will include tyrosinemia, galactosemia, mitochondrial bile acid synthesis defects like progressive familial intrahepatic cholestasis. They would all present as a hepatic encephalopathy. Or some of the metabolic disorders can have dysmorphic like glycogen storage disorders. They would have doll-like facies, Smith-Lemli-Opitz syndrome, where there will be cleft lip palate or the ambiguous genitalia. Some fatty acid oxidation defect, Pompe disease, they can present with the cardiomyopathy. So we need to. So what are the baseline investigation when we are suspecting the inborn errors of metabolism? We should order the complete blood count with the differential, high ammonia, lactate, blood gases, an iron gap, then glucose, urinary and blood ketones, renal function test, and the liver function test. These are the baseline investigations whenever we are suspecting an IEM. Then urine for the reducing substance, the galactose can be identified, the fructose intolerance, pentosuria, alkaptonuria. If we are suspecting the maple syrup urine disease, the urine for metabolic test can be DNPH test. In cases of PKU, the phenylketonuria, the ferric chloride test can be ordered. MPS can be identified by urine for toluidine fluid test, and various sulfite oxidase can be identified by the sulfite test. So these are the common baseline investigations if we are suspecting any metabolic disorder. Then there are advanced investigations, and today's focus of discussion is based on these advanced investigations only, which is increasingly being utilized in the diagnosis of the inborn errors of metabolism and newborn screening. And they would include mass tandem spectrometry, gas chromatography, HPLC, that is the high performance liquid chromatography for the amino acids, enzyme assay to diagnose the suspected enzyme like for the Pompe's disease, for the lysosomal storage disorders, for the biotinidase deficiency, and the molecular analysis to confirm the diagnosis of done by the TMS, GCMS, or the enzyme assay. And molecular analysis is also important if we are interested in doing the prenatal diagnosis for the next pregnancy of the mother. So what is mass tandem spectrometry? The TMS is also known as the MSMS. So here there are two mass spectrometers are situated in the tandem. And this is a revolutionary technology which was devised in early 90s, which can detect multiple independent metabolites in a single test. So the basic principle of TMS that relies on the ionization and fragmentation of each molecule or the metabolite into the specific ions, coupled with a robust detection system, which is computerized to provide the results. So the sample is first ionized and made to pass through a series of chambers, which serve a specific purpose of further ionization, then collision-induced dissociation, and further ionization of the daughter ions before reaching a detection chamber that recognizes the individual ions based upon the specific mass to charge ratio. So there are two spectrometers arranged in the tandems, and they are fragmented, and then the So this increases the sensitivity and the specificity of the metabolic disorder in question. And the overall data is analyzed by the computer, and which provides the highly accurate result of the each analyte. So the utility of the TMS is multifold, and its applications are expanding. It measures amino acids, organic acid disorders, fatty acid disorders in the form of acyl carnitine esters. And this particular technology forms the core of the expanded newborn screening throughout the developed world. TMS does not screen for many IEMs such as mitochondrial disorders, purine and pyrimidine disorders, CDG and VLCFA, that is a very long chain fatty acids. And TMS using dried blood spot is highly sensitive, but not as specific, and thus this remains a screening test for majority of the disorder, and its use for the prenatal diagnosis is not recommended. So what are the advantages of the TMS? So this is one test for many disorders, like more than about 45 disorders. They can detect and quantify many molecules of similar physiochemical properties at the same time. And this is a high throughput technique and a very cost effective. So this is suitable for the mass screening as well. And it reduces the false positive and false negative result relative to the old conventional methods, and improved relative sensitivity of the analysis. And this covers a multiple group of disorders like organic acid and amino acidopathies, fatty acid oxidation disorders. But there are few challenges with the TMS, that only the limited group. So there are over 500 known genetic metabolite disorders, but the TMS is being widely known only for the 40 to 50 of them in a single test. And this is non-specific for the organic acid analysis, which is the most common among the IEM. And for positive indicated cases, repeat screening and a confirmatory test results in a loss of time, thereby increasing the risk in the emergency cases or the NICU cases. And the cutoff may be different for the newborns or for the children which are older than 30 age. And batch processing is required, so emergency cases need to wait. So, and TMS uses the point analysis under which only one marker is analyzed for a disorder. And the same marker can be elevated in the several disorders. For like example, the PKU, that is the phenylketonuria, is a marker used to indicate the disorder PKU. And phenylalanine can also be elevated in 5 other disorders, like disorders of biopterin synthesis, biopterin cofactor, GTP cyclohydrolase, and benign hyperphenylketonuria. Similarly, the C5OH, which is a marker of the severe disease such as the hollow carboxylase, this is also a marker for a very benign condition that is called 3-methylcrotonil coenzyme carboxylase deficiency. So initiating a specific treatment in these cases becomes a challenge because of the ambiguity. So in the next advanced state, so that to bypass many of the problems faced by the TMS, the GCMS, which is the gas chromatography mass spectrometry, to detect the metabolites which are specific for the small molecule disorders, typically the organic acid and related, and this is based on the urine. TMS is done on the blood sample. And the organic acids here are volatile, and they tend to evaporate without preservation, which requires that the sample transported should be frozen. And detection of organic acid in the urine should ideally be done in the frozen sample, or reliably if transported under the ambient temperature, which should not exceed 25 degrees centigrade. So the transportation is stable when the urine sample is put on a special grade filter paper that is able to soak in all metabolites and fix or stabilize it for preventing from the evaporation. And after this, once they are fixed on the filter paper, they can be eluted back from the filter paper into the liquid solution using the simple techniques. An interpretation of the result of the GCMS, that of course requires expertise and the biochemical background training, and thus should be taken up only by the specialized generic laboratories or institutes. And this modality can also measure the metabolites in the bile, plasma, and other body fluids, including the postmortem sample. So what are the key features of the GCMS? That is about 111 disorders can be covered by one analysis. So simultaneously, this keeps the per disorder cost very, very low. And 2 to 5 times markers per disorder makes possible immediate accurate detection and hence an early initiation of the treatment, and no age criteria. And urine sample is non-invasive, so easy logistic of the dried urine sample for far and wide reach as well as direct to home screening is possible. And several group of disorders in a single test can be analyzed, which include amino acid disorders, organic acidemias, fatty acid oxidation defects, lactate pyruvate TCA cycle, paroxysmal disorder, purine and pyrimidine biosynthesis, and disorders of the sugars. So the GCMS that uses a planar analysis, so this has got high specificity. And for example, for PKU, 5 markers are studied. Is like in TMS, just 1 marker is studied. So here there will be 5 markers, so which increases the specificity of the diagnosis of the PKU. For the MSUD, there are about 6 markers which will be studied, like leucine, other branched chain amino acid, isoleucine, valine. So this increases the specificity. So simultaneously, the disorder can be confirmed and the treatment can be started immediately once the diagnosis is done. Then the other advanced test in the field of the IEM, which is of importance, is the urine or the blood HPLC or ion exchange chromatography, and the measurement of specific amino acid in the body fluid like plasma or the blood or urine or the CSF is being utilized widely for the diagnosis of the many amino acid disorder like PKU, tyrosinemia, MSUD, and homocystinuria. So there are multiple methods for quantifying the amino acids, chromatographic as well as the electrophoresis. Most laboratories, they currently employ either the HPLC or urine UPLC technique because of the relative ease and the high specificity. And all samples for chromatography or electrophoresis should be transported in a frozen condition using the dry ice. And sample exposed to high temperature and harsh conditions will destroy the amino acids and they will give the erroneous or the inaccurate results. And sample can also be collected in the sulfoxylic acid pre-treated vial to ensure the stability. CSF samples should be paired with the plasma sample for accurate interpretation. So the diagnosis of non-ketotic hyperglycemia will be made when both the CSF and the plasma level of glycine are elevated. So we have to transport both the CSF and the plasma. Isolated elevation of glycine may be due to other non-genetic causes such as perinatal asphyxia or the bloody tap. So detection of the amino acids qualitatively in the urine, and sometimes both the urine as well as the plasma, has also been used traditionally for the diagnosis of the amino acid disorders. And the test is done by a thin layer chromatography technique. That is a simple test using the filter paper, and the pattern of excretion of the amino acid is then interpreted to reach a diagnosis. And finally, the molecular genetic testing, if there any specific gene, if the diagnosis is very clear, like if we are very sure that this is Pompe disease only or the galactosemia only. Otherwise, if the diagnosis is not very clear, even the current approaches, there are many laboratories which are directly from the newborn screening sample. They are doing the NGS to reach the confirmatory diagnosis. So now coming to the actual topic, that is the newborn screening. So what is newborn screening? NBS is a simple, inexpensive, but effective method to identify the pre-symptomatic neonates to advocate timely interventions that prevent the mortality and long-term morbidity resulting from these enzymatic defects. It aims at pre-symptomatic detection in the newborn period for the inherited metabolic disorders, endocrine disorders like hypothyroidism, congenital adrenal hyperplasia, hematological disorders like sickle cell anemia. Such disorders, they may not be detected otherwise before the affected infant presents with devastating neurodevelopmental sequelae. So the history of newborn screening, actually this begins with the pioneer work done by Dr. Robert Guthrie, who utilized the filter paper for sample collection, and something that is still used across the world in the NBS program. Population screening began in the 1960s in the US and started with the PKU as the first condition to be screened. Once when the Dr. Robert Guthrie was asked, what is your most important work which you have contributed to the world? And they said that I'm always, linked with the PKU, newborn screening. But actually the thing which I feel is the most important is the detection of the using NBS by the use of the filter paper. So according to him, the most important contribution by him is the innovation filter paper for the newborn screening, which is still being used for the newborn screening. So the newborn screening is the practice of testing every newborn for the harmful or potentially fatal disorders which are not otherwise apparent at the birth. NBS is a simple test taken at birth to enable the early detection of the conditions in the babies. And this is a public health activity. Condition screens are individually rare, but collectively more common. And this should be offered to the all newborns. So purpose of newborn screening is to enable the early detection of the pre-symptomatic babies, to enable the early treatment to improve their health, to reduce the anxiety caused by uncertainties over the symptoms before the clinical diagnosis is made, and thereby secure the baby from any health complication in the future. Most of these newborn screening disorders, they are the autosomal recessive disorders, and with the exception of the congenital hypothyroidism, which may be autosomal recessive very rarely, but generally they are sporadic only. So the risk for each pregnancy, if both the parents are carrier of a IEM disorder, is about 25%. So NBS program has been hailed as one of the top medical triumphs of the 20th century. It is a public health program which aims to prevent the catastrophic health consequences through the early detection, diagnosis, and treatment of these disorders. And ideally, the system should reach all newborn, and as advocated that it should be free for all newborns. So the components of NBS is much more than merely a testing activity. It has been published by Professor I.C. Verma in about 2014 in IJP that it has got 6 components, which includes first, the education of the parents or the public regarding the purpose and the utility of the newborn screening, so that they accept the newborn screening program and permit their babies to be tested. Then the second step is the screening of the babies, which involve the collection of the sample, its submission to the central laboratory, testing of the sample, and storage of the filter paper specimen. The diagnosis consists of assessment of the result by the persons with appropriate training and preparation of the report. Then after the diagnosis, this is very, very important step, that conveying the report to the parents or to the doctor immediately by telephone if abnormal, or by the mail if in cases of the normal result. In cases of positive result, it is required to provide counseling to the family also. And follow up if the results are positive. So that comprises recall of the patient, repeating the test, and confirming the diagnosis by different biochemical or DNA analysis. Then after the diagnosis is confirmed, then management comprises the treatment, the periodic examination, and monitoring for the long-term outcome. And then follow-up monitoring and evaluation of the program through the quality assurance outcome and the cost effectiveness. So here at the birthing facility, then on the filter paper, the blood is collected, then the specimen is sent for the laboratory, and the laboratory, after the result, then if the results are positive, then they can be referred to the counselor or the geneticist, and confirmatory testing can be done. So this is the newborn screening process, which involves all the 6 steps as suggested in the literature. So the evolution of the newborn screening in the terms of a scope, that is, when it was started, it started with the PKU. Then gradually 5 disorders were included, which included hypothyroidism, CAH, cystic fibrosis, and of course PKU. Then later on, when the TMS came in around 2000s, then about 50 to 60 disorders. And in the current time, there are more than 100 disorders which are being screened. So over the past 50 years, the newborn screening has followed a natural curve of growth in terms of the 2 parameters, that is the increasing number of the disorders to be screened, and also the increasing accuracy of the screening results. And also it is not only the number of disorders, even the technology is evolving. So initially it was the enzyme assays or the immunoassays ELISA, and which is of course is still being done for Bio7. Then followed by in about 2000 year 2000, MS came into place, which expanded the newborn screening. And now we have the TMS and the ELISA both being done for the most national screening programs. And many of the laboratories have started doing the GCMS, which has got larger number of the disorders. And HPLC is also being done. So in the current, the ELISA then the HPLC, that is the high performance liquid chromatography for amino acids, TMS and GCMS, all are being utilized. So there is an increasing number of technical advances in the newborn screening. So these are the very important technical steps, and which is being utilized in the newborn screening. So the criteria for the inclusion is the same which has been published by the Wilson and Jungner long ago in 1968, and that says that the disorder should be a biochemically well-defined disorder, and the incidence in the population should be known. This should be associated with a significant morbidity and mortality. Effective treatment is available, and the period before which the intervention improves outcome, that should be known, and availability of an ethical, safe, simple, and the robust screening test should be available. So the universal newborn screening is done by a heel prick dried blood sample that has become an integral part of the public health system in the developed countries. And mandatory universal newborn screening was first introduced for the PKU in Massachusetts, United States in 1963. And over the last 5 decades since then, with the technological advances, especially the TMS and immunoassays, the NBS is expanded to encompass several disorders. So as per the American College of Medical Genetics and Genomics in about 2007, they realized that there should be a guideline for the disorders which should be included in the newborn screening, and they included a core panel for that screens for 29 disorders, which include 9 organic acidurias, 5 fatty acid oxidation defects, 6 amino acid disorders, 3 hemoglobin disorders, and 6 others like hypothyroidism, CAH, biotinidase deficiency, galactosemia, cystic fibrosis, and the hearing loss. The introduction of the tandem mass spectrometry was a watershed in the history of the NBS for the metabolic diseases, because through this, the paradigm of one test and many disorders that came into the place. And the MSMS employs a single assay for the multiple disorders and has increased the efficiency with the low cost per sample. And it also breaks the paradigm in the NBS of one test, one disorder. So here, one test and multiple disorders can be diagnosed. So this is the core panel and the secondary target panel advocated by the American College of Medical Genetics, and they include 9 organic acidemias, 5 fatty acid oxidation defects, 6 amino acid acidopathy, 3 hemoglobinopathies, and 6 others. So organic acid, isovaleric acidemia, glutaric acidemia, HMG, then this cobalamin deficiency defects, then in fatty acid oxidation defects, multiple chain acyl dehydrogenase, very long chain, and in the amino acids PKU, MSUD, homocystinuria, tyrosinemia, and 3 hemoglobinopathies, that is the sickle cell, then S beta thalassemia and hemoglobin S and C, so as to start the early treatment, and 6 bio7, which we generally call the hypothyroidism, biotinidase, and GALT, and hearing and cystic fibrosis. And these are the secondary target advocated by the ACMG. So after that, initial panel in the 2007, they did in severe combined immunodeficiency was started in the year 2009 in the newborn screening program. Congenital heart disease, critical congenital heart disease was added in this panel in 2010. Pompe disease in 2013. MPS was added in the NBS in 2015. X-linked adrenoleukodystrophy in 2018. SMA was added in 2018. And recently, Hunter syndrome, that is the MPS 2, was added in 2022 in this core panel of 29 disorders. So what should be the suggested protocol for India? We feel that this should be universal 7 diseases for all children born. That is the hypothyroidism, CAH, PKU, galactosemia, cystic fibrosis, biotinidase, and G6PD, which are diagnosed usually by the fluoroimmunoassays. And then there could be expanded NBS, basic 7, that is these basic 7, plus the disorders by the TMS or GCMS. So depending upon the cost, whether it is a private healthcare or the public healthcare, so expanded NBS can be introduced. So what is the status of NBS in India? The first study of the newborn metabolite screening was carried by Dr. Appaji Rao and colleagues in the Bangalore to examine the effect of consanguinity on the amino acid disorders. Subsequently, small-scale studies were carried out in some hospitals, although recently many private hospitals have initiated the newborn screening on a payment basis. Then the ICMR initiated through a task force on inborn metabolic disorder, a program to screen neonates in the 5 centers in India like Delhi, Mumbai, Chennai, Hyderabad and Kolkata. And this study lasted from 2007 to 2012, that is for the 5 years. And the overall number of newborn were about 1 lakh for hypothyroidism and again 1 lakh for CAH. And the incidence of hypothyroidism was, congenital hypothyroidism was overall 1 in 130, that is around 1 in 1,000. And varying from 1 in 727 in Chennai to 1 in 1528 in Mumbai. And the incidence of CAH overall was 1 in 5,000 around, and varying from 1 in 2,000 in South India, Chennai, to 1 in 9,900 in Mumbai. So this study provides good information on the actual process of screening and how to set up such a program. Then at the highest level of the national government, the benefits of the NBS have not been fully understood. And as a result, no national policy on the NBS has been created in our country. So the private NBS programs, the private hospital have taken the lead for the newborn screening in India, and most of which have physicians who have been exposed to the newborn screening while they were training abroad. And the panel ranges from the 3 disorders to the comprehensive set of the 50+, which is widely followed in the US. Then there in the public NBS programs, a screening program in the public hospital, they have the potential to achieve the universal screening. About 52% of births in India are in public hospitals where the cost of the delivery is less. And since the cost of services in these hospitals, including the NBS tests, are free, it is possible to screen all babies born in the public hospitals. So there are 3 public screening programs. One is the Chandigarh's NBS program, is concentrated in 4 urban government hospitals, and that screens about 15,000 births per year. Goa screens approximately 12,500 births per year in 13 government hospitals. And Kerala, the public screening, that is screens for more than 140,000 births per year in over 90 government hospitals. But none of these programs screen births in the private hospitals. All these programs, they screen for panel of disorders that are well understood by the physician in India and easily treatable. Disorders is screened by MSMS, that is the fatty acid oxidation defects or the organic acid or the amino acidopathies. They are not the part of the screening panels due to the resource constraints like significant cost, few experts, lack of treatment facilities, and high cost of the diets. So in these studies, the common metabolic disorder is as identified by the TMS or GCMS. In one ICMR multicentric study of 708 high-risk infants were also tested at the 5 centers by the TMS, and they identified 16 cases of urea among these 700, 16 cases of urea cycle disorder, 16 of the MSUD, 24 of the methylmalonic aciduria, 12 of PPA, 19 of the glutaric aciduria. So all these organic acidopathies, they are common in our countries also. So they concluded. Then Dave and Ranjan, they presented GCMS studies on the urine in 3,195 high-risk infants, and they identified MMA, glutaric aciduria, urea cycle disorder, MSUD, propionic acidemia, beta-ketathiolase, Canaman disease, like any other developed country. So the disorders were not uncommon. In these in the studies published in 2018, we can see here the incidence of congenital hypothyroidism in India, like 1 in 833 in Delhi and UP, then 1 in 1700 in Andhra Pradesh. In Chandigarh, it is less, 1 in 3400. Then Tamil Nadu, 1 in 900. And in Kerala, this is very, very high, 1 in 244. So these are the incidence of congenital hypothyroidism in the published in the literature. Then CAH, we have Delhi, from Delhi, Professor I.C. Verma, that is 1 in 4,000 around. Then in Chandigarh, 1 in 6,000. And in South India, it is little higher in Andhra Pradesh, 1 in 2,575. And in the multicentric ICMR study, this has identified, which included centers from Chennai, Delhi, Mumbai, Kolkata. The incidence is around, we can say, 1 in 6,000. G6PD deficiency has been ranging from 1 in 29 to 1, we can say 1 in 200. So these are quite common. So the identification is important so that these children can be informed about the drugs which needs to be avoided. Then what is congenital hypothyroidism? Here there is inadequate thyroid hormone production. It could be due to the absence of the gland or dyshormonogenesis, or could be iodine deficiency. And which, if untreated, this will lead to the intellectual disability, decreased growth and bone maturation, neurological problems, and autistic behavior. Diagnosis made before 13 days to prevent the symptoms, and the treatment is thyroid hormone replacement. So this is easily available even in the rural areas also. So that's why this is included in the universal, and even in the public health setting, this test can be done, and the children can be treated in time. Then next disorder, which is important from our perspective, is CAH. So what is CAH? This is an impaired synthesis of the cortisol by the adrenal cortex that leads to increase the androgen biosynthesis, and that leads to the inability to maintain the adequate energy and the blood glucose level to meet the stress of injury and illnesses. So they could be the salt wasting, or there could be the salt wasting form is the more severe one, which will lead to failure to thrive, vomiting, dehydration, hyponatremia, or there could be the simple virilizing form presenting as the ambiguous genitalia. And in this month only, we had 2 cases of CAH in our centers where I work, and both were the simple virilizing forms. So meaning thereby that these disorders, and the couple were asking me how this was not possible to diagnose during the pregnancy. So we need to educate the public that CAH can be preventable by the carrier screening, or in the next pregnancy, prenatal diagnosis is important after the molecular diagnosis is confirmed. Then the sickle cell disease, and this is common in the tribal areas of our country. And here the change in the shape of the beta globin of the hemoglobin molecule, which interferes with the hemoglobin's oxygen carrying capacity. And the main symptoms are painful crisis, or there could be a chronic hemolytic anemia. They can have frequent infections and chronic organ dysfunctions, and there could be history of a stroke, there could be renal problems. So this affects multiple problems. So although this disease does not lead to decreased survival, but the quality of life is so poor that even the prenatal diagnosis is advisable for this particular condition. And the diagnosis in the newborn period is done by the hemoglobin electrophoresis by checking for the hemoglobin S. And the treatment, once the diagnosis is done, then they can take the prophylactic penicillin, and there is a 84% reduction in the infections, or they can give these vaccines, and there could be the aggressive treatment of the fever and dehydrations. Then another disorder, that is the biotinidase deficiency. Biotinidase is responsible for the recycling of the biotin, which is a cofactor for the biotin-dependent carboxylases. And the symptoms would include ketoacidosis, organic aciduria, seizures, hypotonia, developmental delay, vision problem, hearing problem, skin problem, hair problem. And the treatment is, once the diagnosis is done, it is a very rewarding treatment. And treatment is very, very simple. Just 1 tablet of 5 milligram or 10 milligram of oral biotin per day. And this prevents the long-term treatment and prevents all the symptoms. So it is actually very, very rewarding to diagnose the biotinidase deficiency in a child which has got the seizures, and the TMS is suggestive of biotinidase, and the biotinidase enzyme assay confirms that this is biotinidase. So it's actually very, very rewarding to treat such. Then another common inborn error of metabolism is galactosemia, and the lactose is the main sugar in the breast milk and the infant formulas, and this is metabolized into the glucose and galactose in the intestine. In galactosemia, these children are unable to break down the galactose, and they will have failure to thrive, bleeding, infections, liver failures, cataract, mental retardation. And the treatment is simple, that is the lactose galactose restricted diet, and this must be started in the first 10 days of the life to prevent the symptom. And even with the treatment, even sometimes the developmental delay, speech problem can be done. So the early the diagnosis and the better is the outcome. Then the cystic fibrosis, which is due to the mutation in the cystic fibrosis gene. And this cystic fibrosis leads to the chronic recurrent respiratory tract infections. There could be the gastrointestinal problem like recurrent diarrhea, or even in the males, this can present as the male infertility. There can be salt loss syndrome, or usually the quality of life is poor, or there can be a shortened lifespan, and there are treatments available. So it's important that the child is diagnosed in time. So organic acid disorders, so what are they? The body cannot metabolize the certain amino acids and fat, and accumulation of the organic acid happens in the blood and urine, and this has a serious potentially preventable effects on the health and development, and even including the death. And they would present as acute encephalopathy, vomiting, metabolic acidosis, ketosis, increased ammonia, hypoglycemia, dehydration, failure to thrive, global developmental delay. And the treatment is simple, that once the diagnosis is low protein diet or the restricted protein diets or the supplements. So these are the common organic disorders, organic acid disorders: isovaleric acidemia, glutaric acidemia, methylmalonic acidemia, propionic acidemia. These are quite common organic acidemia. Then the fatty acid disorders, they result because of the breakdown of the fatty acids in mitochondria, is an essential part of the body's ability to produce the energy. So in this disorder, there is inability to break down the fatty acids to produce the energy. And the symptoms, they decompensate with any metabolic stress like fever, fasting, any intercurrent illness, and they would present as hypoglycemia, liver problem, muscle problem, and seizures, coma, and even sudden infant death syndrome. And the treatment is avoid fasting, IV glucose. So once we diagnose, the treatment is possible. And the common fatty acid oxidation defects are MCAD, very long chain fatty acid disorders, carnitine uptake defects. Then what are the amino acid disorders? They occur when the body cannot either metabolize or produce the certain amino acids. So they result in the toxic accumulation of the substances and serious potentially preventable effects. And they would present as hyperphenylalaninemia, microcephaly, epilepsy, mental retardation. And the treatment is to reduce low protein diet and supplement cofactors or essential amino acids. And they are PKU, MSUD, tyrosinemia, which are the common amino acid orthopathies. So now coming to when to introduce the newborn screening in country. So as reported in the literature, that introducing the NBS is akin to the introducing genetic services in our country. And the WHO has often recommended that the genetic services should be introduced in countries with the infant mortality rate less than 50. So if we apply this criteria to our country, the urban areas in all states, they should introduce newborn screening and genetic services, as the IMR is less than 50. The IMR in rural areas in all states except the Assam, Madhya Pradesh, and Rajasthan is less than 50. So even the rural areas also are candidates for the newborn screening. And the combined IMR in the following states is 25 or less, like Goa, Kerala, Daman and Diu and Pondicherry, Chandigarh, Lakshadweep, Sikkim, Delhi, and Maharashtra. So these have got reduced, very, very reduced IMR. So clearly these states, they deserve to have the universal newborn screening. And this is done as a heel prick method on the sides so as to avoid the injury. And this is the filter, and the lancet is used on the side of the heel. And this is the filter paper on which this is collected. So NBS is conducted by collecting the few drops of blood from the baby's heel to test for the metabolic disorder. And this starts with blood collection, typically between the day 2 and day 5 of the birth. Dried blood spot is a preferred method as it is easy to transport the samples. And babies which are born premature, they may require a repeat testing. So this is the sample collection technique from the heel prick method. So we can see here the prick is given here, and then the filter paper. So there are about 5 spots where the blood is collected. And this is an acceptable specimen. And here there is no blood. Here the quantity of, in this type of filter paper, the quantity of blood is insufficient. This is not a good blood sample. And the blood sample should always be dried before putting into the plastic container. So this is not a good sample, because this was a wet sample when it was packed in before the transport. These are the super saturated blood spots. These are the diluted. So one should aim to have the filter paper like this. So what are not to do in this? So do not color the filter paper circles. Do not apply multiple drops of blood per circle. Do not scratch the filter paper. Do not contaminate the specimens. Insufficient drying of alcohol, oils on the hands, lotions. Do not stack the specimens. And risk for cross-contamination. Do not submit the wet specimens. Do not place the specimens in the direct sunlight or in front of the air vents. And do not place wet specimens in the plastic bags, and do not batch into this specimens. So the filter paper is a part of the NBS form. It is a medical device designed to observe a specific volume of blood within each pre-printed filter paper circle. If an analyte for any disorder is either too high or too low, this is an indication that the additional testing is needed. An accurate result depends upon the proper absorption of the blood onto the filter paper. Too much or too little blood can result in the inaccurate results. So although it appears simple that it is just a collection of blood sample also, but this has to be meticulous, that the sample is collected very in a good manner, so that all the circles are filled properly. So then the question arises, are all 5 samples needed? So yes, because if the result is flagging out of range, the specimen will be retested, and the result will be an average of the 3 results. And each test requires an additional punch to be taken from the pre-printed circles. If the results of the CAH, biotinidase, they are out of range, then the 2 entire pre-printed circles can be removed and shipped to the other genomic labs for the confirmation, for the genetic confirmation. This is the Perkin-Elmer-Delphia system, which uses the time-resolved fluoroimmunoassay technique for the CAH. And then when should be the newborn screening? So ideal time of sampling is after 72 hours and within 7 days of life. The reason being that by the time the feeding is established. So, but in the current policy in India, that most of the birth discharges, they happen on the 2nd day. So this is very difficult to adopt due to high birth rate and limited space in our hospitals. So this can be ideally be done even at 24 to 48 hours of life, when the enteral feeding has been established and renal function is improving. And so it can, in the current scenario where the discharges are happening so soon, so even the day 2 is sufficient. We have to just see that the proper feeding has started by day 2. So that is very, very important. If the child is premature, then collect the specimen when the child is 5 to 7 days old. And if the TPN, then indicate this on the newborn screening. If the child has received transfusion, then it's better to wait for 60 days. Ideally, one should be vigilant enough to take the sample before the transfusion is started. But in most of the cases in a busy nursery, we tend to forget this. So ideally, if the blood transfusion has happened, that it should be done only after the 60 days of the newborn screening should be started. So once the newborn screening has been done, it's very, very important to communicate the result. The positive result from the newborn screening should have confirmatory test performed as quickly as possible, and they must remain vigilant to the development of the disease, as the negative result does not rule out disorder even if this screening is performed. So the false negative must be informed to them. There are many challenges, that the use of the residual dried blood spot specimen, identification of the late onset disorders, identification of certain conditions for which treatment is not yet established, and identification of carrier resource allocation. So with this, so Krishna, can I continue with the cases? Do we have time?
Yes, ma'am. We can continue, ma'am.
Yes.
Yeah. Okay. So now we have taken some few cases. Like this is a very recent case, 20 days old, and he was referred to us for the G6PD in an asymptomatic child detected by the newborn screening. And as there are many newborn screening labs which also confirm the pathogenic mutation, so for this, the child was referred to us at the day 20 of the life. So we counseled the family about the risk of hemolytic anemia when the child was exposed to certain drugs. And we did the G6PD quantification done again, and that showed that actually the child has got the G6PD deficiency, and the management is avoidance of the precipitating drugs. So this literature was given to them. This is a case which explains the missed opportunity and what the devastating consequences this baby faced. That this baby, actually mother came to us during the next pregnancy that this baby has got congenital hypothyroidism, and this was detected at when the child was 1 year old. At that point of time, the TSH was 150. TSH was 150, and we can see here the free T3 and free T4. They were very, very low. Thyroid ultrasound was suggested, and that suggested no thyroid gland. And thyroid scan was not done because of the lack of funds. Then the mother had consulted for the recurrence risk in the ongoing pregnancy. So we said that the congenital hypothyroidism can be due to the dysgenesis of the thyroid gland or dyshormonogenesis. Workup of the previous child for the etiological diagnosis has not been complete, but the one ultrasound thyroid has been done, which showed that there is an absent thyroid gland. Thyroid scan was not performed. So the thyroid dysgenesis, that is the absent thyroid gland, is generally thought to be sporadic in occurrence. However, there are recent evidence points to the possibility of the genetic component. And recently only we came across one family where there are 2 children with the absent thyroid, and this is a consanguineous family. So the one study of all cases found that the thyroid dysgenesis can be 2% familial. So we suggested them a detailed level 2 ultrasound for the visualization of the thyroid gland in the fetus, and thyroid was on the level 2 ultrasound. At 28-week scan, we kept on reconfirming the thyroid gland, and which was present in the ongoing pregnancy. And this baby at birth, the TSH was normal. Then CAH, this children would present as clitoromegaly, no gonads palpable, and there will be raised 17 OHP. Ultrasound will show that the uterus is present, and karyotype is the 46XX. Biotinidase, this is a 1-year-old girl which was born to the consanguineous parent, and she presented with the seizure and the developmental delay. And this child also was diagnosed at 1 year, and because the parents had come to us for the prenatal diagnosis. So as is our, we would always work up the index case, and we did the TMS and the Bio7, and we found that there is a profound biotinidase deficiency. We had already ordered the whole exome sequencing trio. So when we found this report of the biotinidase deficiency, we immediately informed the testing laboratory that this fetus, this baby, the index case has got profound biotinidase deficiency, and they found a homozygous indel variation in the biotinidase gene, which results in the frame shift and the premature truncation. Parents were carrier, and the fetus, this ongoing pregnancy was a carrier only. And after this, the treatment was started, and the results still has been very remarkable. Now the girl, which was having seizures and developmental delay, is almost up to the normal child only, although the treatment was quite delayed. The maple syrup urine disease, this is the 13 days female, and baby cried at birth, full-term normal delivery. At day 6 of life, she presented with the lethargy, excessive sleepiness, decreased activity, hiccups, and refusal to feed. On day 9, she was admitted in the NICU with the irregular respiration, 1 episode of seizure, impending respiratory failure, and the baby was kept on ventilation, and excessive cyclic movements were present. Investigation, CSF was normal, lactate pyruvate normal, and the ultrasound was normal. Then the TMS screening that showed elevated level of the leucine, and then it was diagnosed by the GCMS, which showed the elevated levels of the 6 marker, that is the lactate 2-hydroxy isovalerate and isoleucine. So the child was started for the dietary restriction, especially of the branch chain amino acids, avoiding the IV lipid and high concentration of glucose. And because this is a autosomal recessive disorder, so the risk of recurrence for the next pregnancy was also discussed. So the MSUD, they will present in the neonate with the feeding intolerance, failure to thrive, vomiting, lethargy, and maple syrup odor to the urine and the cerumen. And if untreated, it will progress to the irreversible mental retardation, hyperactivity, failure to thrive, seizures, coma, cerebral edema, and possibly death. TMS will show increased leucine, whereas the GCMS will see multiple metabolites, increased leucine, isoleucine, valine, and alpha keto. So the plasma amino acid analysis, that is the HPLC, that will reveal the elevation of leucine, isoleucine, alloleucine, and valine. These are the branch chain amino acid. And urine organic acid reveals abnormal branch chain amino acids and the keto acids. In expanded screening, leucine or isoleucine and hydroxyproline, they cannot be differentiated. So if the baby has hydroxyprolinemia, confirmatory amino acid analysis will only show the increased hydroxyproline, and this is a benign entity. So this is a fact. This chart algorithm I have taken from the ACMG fact sheets, and this is important for the clinician that if they have identified any disorder on the TMS or GCMS, they can search on this ACMG fact sheet. And here, if there is elevated leucine, like in this case, then what test they would require? They would require HPLC, they will require urinary organic GCMS, and depending upon the pattern, MSUD, benign hydroxyprolinemia, or it could be a false positive. So they can use this website for there. Then the methylmalonic acidemia, the another case, 3 days male and born by LSCS, cried at birth, birth weight was normal, and the child complained of tachypnea after the 48 hours of life. And there was persistent metabolic acidosis. There was an anion gap. Serum lactate was quite high. CSF lactate was also high. And the TMS screening that showed the elevated level of the C3. So this can be either PPA, that is a propionic acidemia, because or methylmalonic acidemia, because the C3 is elevated in the both. So then the GCMS confirmatory test was done, which suggested elevated levels of MMA and methyl citrate. So this was the diagnosis was the methylmalonic acidemia, and the clinician, the child was started on the vitamin B12 and the carnitine therapy. That was started. So this is a case of the propionic acidemia. The TMS again, because here the C3 would be raised, and the GCMS confirmed the propionic acidemia, and the child was again a product of consanguineous marriage. And on the day 21 of life, the child presented with the diarrhea and the convulsions, poor feeding, hypotonia, respiratory distress, and there was no acidosis. Electrolytes were normal, but the serum ammonia was very, very high. And then we did the TMS and GCMS, and of course the mutation was identified. And then the next pregnancy, we performed the prenatal testing. So the patients with propionic acidemia and severe cases of MMA, they will typically present with the metabolic ketoacidosis, hyperomonemia, dehydration, ketonuria, and the TMS in both the cases will show increased C3. And the differential diagnosis, when you see on the TMS of the increased C3, that propionic acidemia and MMA, or even including the defects in the B12, and even the maternal severe B12 deficiency. We had one case where in utero, the child presented with the pleural effusion, and our fetal medicine colleagues, they kept on doing the tapping and they did the shunting also for that pleural effusion. And when the child was delivered, the TMS was sent, and that showed that increased C3. So we said, okay, I have never seen the presenting as the pleural effusion. And then the propionic acidemia, methyl, both were excluded. And finally, we referred the child to the AIMS, where my colleague, she diagnosed as this was a case of maternal severe B12 deficiency, and such a rewarding treatment, and the family was very thankful to my colleague. So the propionic acidemia, this was caused by a defect in the propionyl coenzyme carboxylase, and which converts the propionyl coenzyme A to the methylmalonic coenzyme A. And this results from a defect. MMA results from the methylmalonic coenzyme mutase, which converts methylmalonic coenzyme A to succinyl coenzyme. So lack of the required B12 factor these can also cause this. Here also there is a algorithm for elevated C3, and we can have the succinyl coenzyme deficiency, MMA, or vitamin B12 deficiency, or the PPA, that is the propionic. So this algorithm again is taken from the ACMG fact sheets, which is actually very helpful to the clinician when you identify any elevated metabolites. So to summarize, we have universal NBS. We should include in our country that the basic 7 disorders, CAH, congenital hypothyroidism, PKU, galactosemia, cystic fibrosis, biotinidase, G6PD. Or I feel that now it's high time that we should start the expanded newborn screening, which includes all these basic 7, all the disorders by TMS and GCMS, because the cost has come to significantly down. The time when I started learning all these disorders, like about 15 years ago, when I started learning the TMS and what is TMS, what is GCMS, and at that point of time, each costed around 5,000, like 5,000 TMS, 5,000 GCMS, and we were sending the samples to Japan and preparing those filter papers, transporting them, drying them, transporting them to the Japan in one particular laboratory. And now when the test is available in our country, I feel that all the newborns must undergo these basic 7 and the expanded newborn screening, because now the cost has come to almost half of the price of even the one test. So we can it's high time that we should start. So to conclude, India is going through a progressive transitional phase of control over the infant mortality and morbidity due to the infections and the emergence of the genetic conditions. And the WHO has recommended that the genetic services should be introduced in the countries with IMR of less than 50. So India with an IMR of 40 should introduce newborn screening and the genetic test services. And the Indian Academy of Pediatrics, that is IAP, that strongly advocates the inclusion of the newborn screening in our public health policy. So one little step forward, because what we have realized that there is awareness lacking, and when the child is born, the family, because the family is not aware, not educated about the newborn screening, the benefits of the newborn screening. So the window of opportunity of those 2 days stay in the hospital and is lost. The family is not very familiar with the pediatrician or the neonatologist. So they are not going to listen in that short span of time, 1 or 2 visits where we want to say. And all of us are busy, so neither we say very effectively. And so most of the time the opportunity is lost. So we have realized that we have to begin early about talking of these newborn screening so as to be effective. So the information to the pregnant woman should be given at, there are different times which I realize is important, that the obstetrician or the fetal medicine specialist, they should inform them at the first trimester screen that now we are screening for Down syndrome, but after birth you need to have a newborn screening, which includes more than 50 disorders, which can be treatable if they are treatable in time. The long-term morbidity and mortality can be prevented, and even at the level 2 ultrasound somebody can talk, or even at the time of Doppler. And who is responsible or who should be assigned this work? The maternal fetal medicine specialist, because they are in contact with the obstetrician of the pregnant women, and these are the the obstetrician and the fetal medicine and the genetic specialist whom they would listen to a significant degree. Then the radiologist also can be trained just to explain the utility of the newborn screening, that it helps in preventable disorders which are treatable. And then medical geneticists, the genetic counselors, even the paramedical health workers can be educated, because we have many in the COVID time we have seen how the paramedical healthcare has been utilized. So we should not ignore their energy force, and probably there are multiple times where we can educate these pregnant women so as to be the newborn screening to be effective. So we have to screen early so that we can treat early. So thank you, everyone. So Krishna.
Thank you, Dr. Yeah. Thank you, Dr. Thakur, for such a wonderful and excellent talk about NBS. It was really knowledge filling to all of us. And now the session is open for questions. So we have few questions already in the chat box. I will read out one by one. we can answer. Okay. The first question is, are there any known biological or environmental interferences which can affect the NPS results? Okay.
MPS results.
Yes, madam.
Not exactly, but because I'm not from the lab part, but generally, the urine we send for MPS screen, and if the based upon the clinical symptoms. So basically, first we suspect clinically, and send for the urine for the MPS electrophoresis, MPS, and then followed by MPS electrophoresis. So not much biological factors I'm aware of. So generally, it is a straightforward test only.
Yeah. So thank you, madam, for that. Then I will just add one or two things to this question as well.
Yes.
Okay. See, sometimes the prematurity
Yes,
of the baby or birth weight. Okay. So this can influence even the feeding status. Can sometimes influence the results, or some medications if they are taking, or the fetus is on some medication, that also may affect the results. Or if there is any transfusions or exchanges done for the baby, and the blood is drawn after that, it may affect the things. And coming to the environmental factors, as already you mentioned in the talk, so the collection of the blood and then the wrong DBS filter papers, so may also influence the results. Okay. Then, so we'll quickly move to the next question. So can genetic tests can be conducted directly instead of going for confirmatory chemical tests?
Generally, I would not suggest directly going for genetic tests, because because as you know, the genetic testing are quite complex at times. You may get variation of uncertain significance. So if that correlates clinically with your, like suppose you have a case of G6PD, like I have just shown, that genetic testing was already done, still I reconfirm the G6PD deficiency, because ultimate confirmatory is that only, because as you know that the variation of uncertain significance in the genetic results, they are a big block, they may create a confusion. So it's better to undergo if the chemical tests are available. Like once we had done for homocystinuria, we didn't know that the previous index case has got homocystinuria, and because of the lack of money available, we directly did the prenatal testing for the ongoing pregnancy. And then I got a call from the lab that we are getting the homocystinuria, and do you have the index case sample? Then I told them, see, the patient is poor. So immediately I did the serum homocysteine, and which was very, very high. So although at that point of time, that mutation or that variant was variation of uncertain significance, but still I was confident that we are dealing with the right diagnosis, because this was matching biochemically. So whenever there is a biochemical facility, we always rely upon after any NGS results. So directly going for NBS, I think is not the is not the better protocol.
Okay, thank you for that answer. Now, third question is, will the different vendors or platforms make any difference in quality of results? So I think I can take this question again. So the quality of results, yes, from genetic testing can be influenced by several factors, including the specific vendor or platform used for testing. So different genetic testing vendors and platforms may have variations in the accuracy, reliability, and completeness of the result. Then is the sensitivity or specificity different for different platforms? I think it is very straightforward question again. Yes, the sensitivity and specificity will differ from lab to lab, because they'll be using different platforms, but they will be definitely mentioning that in their reports. So the clinicians need to check the sensitivity and specificity provided by the different vendors. Accordingly, the clinical results should be interpreted. The next question is, what is the gold standard for NBS?
What? MPS.
What is the gold standard for NBS?
Yeah, newborn screening, you mean? Yeah, NBS.
Yes,
okay.
Yes, NBS.
Generally, see,
Yes,
as we just discussed, that the Bio7 and the expanded newborn screening by the TMS, or somebody can even do directly the GCMS also.
Yeah. So,
But worldwide,
thank
it is
you,
the
guys.
TMS which is being used in the, not the GCMS. So it is the TMS being used in the newborn screening.
So there are next two questions which are more or less same. What if parent miss the deadline for screening test? Is there any next window available?
So usually we do, ideal recommendation is to do, 72 hours of birth when the feeding is already well established. But as we discussed that because of the early discharge policy in private as well as the government hospitals, because of the lack of the beds, so even at the, the screening can be done, the sample can be taken even at the 48 hours of birth also when the feeding is already started. And so I think that is the most practical way, that so that we don't lose the family, don't lose the newborn by the discharge, because as we know, after the child is discharged, we cannot get that sample because the family is preoccupied in that child and they forget all those follow-ups. So once they are, while they are in the hospital, so before the discharge, the sample should be taken, so it can be taken at the 48 hours of birth.
Yeah. So the next question is, again, I told you already, it is more or less same, but to address the particular audit say attendee who has asked this question, can newborn screening be done in post-neonatal age? So slightly different from the first question. So they're asking post-neonatal age means maybe 1 year, 2 years
Yeah, the
after
test
birth.
is the same. So suppose the child presents, you didn't, screen that child, or maybe it was a false negative. So even if the child is symptomatic, or even if the asymptomatic also, the test can be done in the later on. There is no problem in that, except the IRT for cystic fibrosis, which is only possible in the neonatal period. Otherwise, all the tests, the TMS, the other Bio7, they can be done at any point of age, even if they miss the opportunity. So if they come to you for the first time for the vaccination and the child looks healthy to you, you can again, you can take the samples after educating the family, the couple, then they can decide for the TMS. And most of them, I have realized that if you inform them properly, they are going, like we have seen in the case of stem cell banking, though it is quite expensive, but still most of the families in the private sector, they are undergoing. And what I have seen, that the newborn screening, even in the best of the private hospital, this is not universal, even in Delhi also. There are very few hospitals. When I had to present this presentation earlier, and I had asked few of my colleagues, and they said, no, we are only doing the symptomatic newborns. We are not testing the universal newborn screening. And then I was taken aback that when the technology is such a good and it benefits a lot. So I realized that probably it's high time that the obstetrician should start talking to this. Unless they start, they cannot, the family is not going to listen, because they are the most powerful person in the mother and the child program. So the obstetrician this recommendation has to come from the obstetrician, and obstetrician needs education what to talk for the newborn screening, its benefits, and then probably the programs can be started universally.
Yeah. Okay. The next question is NBS can't be detected in microarray? So I will take this question. So yes, microarray cannot detect the NBS markers, whatever we are offering, or whatever is available as per ACMG guidelines, because microarray deals with the gains or losses. Of course, if there is any marker which has the deletion or gain associated with that, that can be detected using microarray. Okay, next question is it is only amino acid metabolism error is more predominant than other metabolism?
No, organic acidemias are the commonest. So
Yeah.
like MMA, propionic acidemia, they are common. Even the amino acids, they are common. So overall, they constitute about 1 in 1,000, the inborn errors of metabolism.
Yeah. So next question is, what will be the maximum period to collect the sample for NBS? I think already this question is answered. So again, to give them an answer, it's as early as possible, it will be better. So within 24 hours will be better, but if it is missed, at least within 48 or 78 hours, it will be better. Then I have done certificate course in genetic counseling. How should I start practicing? I think this question is not relevant to the scope of today's discussion.
But yes, they
Madam,
can
do you want to
join some medical
answer? Yes.
geneticists. They should work with medical geneticists, not alone, because the training in our country is not like that. A genetic counselor should work separately, because the genetic diagnosis is we have to make a genetic diagnosis, so it is not possible by the genetic counselor. So they can only talk after the diagnosis is made. So all its advice for all the genetic counselor that they should join those centers which are already with having the medical geneticist, where they can help the medical geneticist in this at the same time and do the job.
Yeah. So next question is, can you please put some light on scope of NGS in NBS, next generation sequencing in newborn screening, considering high cost per test?
There are many companies which have already started as a second tier test. The moment they identify that this is a inborn error of metabolism, then immediately from the same dried blood sample they would do the NGS to do the confirmatory, as I have just shown in the G6PD. The lab diagnosed by the the G6PD deficiency, and immediately they did the NGS. Probably it is their protocol that in the same cost they will do the NGS. So that's why we keep on asking that if we do early it will be very, very cost effective, because we have to know that also, that if we do at the newborn period, the NGS will be free for the child. So that's many labs which have started doing, and at no extra cost generally.
Yeah. So thank you, madam. So next question is, there is confusion regarding screening of hemoglobinopathies for the newborn due to high level of treated HB. Please clarify.
Yes. So here even this question I am always asked, that how do you, because there is already hemoglobin F high, so how do you distinguish? So it's not on the basis of actually hemoglobin F, it is actually on the basis of hemoglobin S or the presence of hemoglobin A, because by the as we all know that there is a switch to hemoglobin A. So if a newborn has got even the slightest amount of hemoglobin even if the preterm also, they have the hemoglobin A, that excludes the major thalassemia. And even the smallest amount of the sickle hemoglobin that can be can be detected by the HPLC. So it's not by the hemoglobin F, it is the other way around. So even I used to wonder, and this question I get at every NBS where I discuss about this. So it's the other way around, not by the F.
So the next question is negative screening results. What confidence level to not to go further testing on low weight birth or early pregnancy delivery?
Like as we know that any test has got its own limitations. So once we have done the newborn screening and this was normal, it may be that some of the disorders, they will be only manifesting, or the metabolites, when the the child is having the problem or the child is symptomatic. So we need to have the high index of suspicion. We should not rely that the previous test was normal, so now this cannot be IEM. We should still work up, as if you have the symptoms like lethargy, encephalopathy, raised ammonia, raised lactate, acidosis. So all these things, we need to redo the test again when the child is symptomatic.
Yeah. Next question is, I think it is for lab. Can we add sickle cell mutations in Bio7 in Maharashtra, because sickle is most prominent in Maharashtra? So we can look into this, and then wherever it is possible, we can add it. Can filter paper test be done in post neonatal age?
Yeah, they are doing the same.
Yeah.
It can be done in the similar manner. It doesn't mean कि within 7 days ही होना है. जब भी baby आए, तब भी ये test कर सकते हैं. There is no difference.
Do MedGenome hire genetic counselors? How to get associated? Please guide sir and madam. So MedGenome hires genetic counselors. So you can reach carriers@medgenome.com. You can write to carriers@medgenome.com, and then our HRs will be in touch with you. Okay. Then, do you have comparative analysis for testing performed on Victor 2D, or any better choice of technology selection?
I think they are all
Shall I
doing
take this?
Yeah.
Yeah. So Victor 2D, yes, comparison is done with Victor 2D or any other available platform in the lab. So in our labs, we usually do it with LCMS, for example, LCMS. If you have a platform like LCMS, so we do on LCMS, and then same sample will be sent to other lab, inter-lab comparisons. So this will be what you say between two labs comparison, and then that will give more confidence as well. Okay, or it can be on two different platforms as you are mentioned. Can you please explain a little bit about HBE trait and HBE disease?
Yes, yes. So HBE disease means homozygous person, and E is carrier, that is just one heterozygote. So usually, the hemoglobin E homozygous, we get lots of referrals during pregnancy where both the couple is hemoglobin E trait. Most of the people are from the Northeast or Bengal, where this is a very common carrier status. So the homozygous hemoglobin E disease will lead to only mild anemia. So we do not suggest prenatal testing for that. But suppose there is a combination of beta thalassemia, one partner is E trait, but the other is beta thalassemia, then prenatal testing is indicated because this may lead to thalassemia intermedia. So this may become transfusion dependent. Then there could be a combination with hemoglobin E and S. So they need prenatal testing, but the homozygous hemoglobin E does not need prenatal testing because majority of them are very mild anemia, which does not require any blood transfusion.
So there are no more questions. Madam, I have one question. So India being the second most populated country, not now I think it is first most populated country in the world. Yeah. But there will be around 60 or 70,000 babies born every day. But I don't see so many tests happening. So what will be your message to the audience here, and then how to take this forward in a country like ours?
Yeah. So, the test is available. What I have realized, the test is easily available with so many vendors. But the people, those who are ordering it, they are not, well versed with what to tell about the utility, the importance of the newborn screening. And here is the gap, so that's why probably I discussed that, it's the turn of obstetrician to enter into this area also. Till now the pediatricians were doing, but I have realized even they are not able to answer, because as a patient will have lots of queries that why you are doing, what are the symptoms, and what is the cause. So most of the clinicians, they are busy in the routine care, so the prevention comes at the last bench. So probably if we start doing from the pregnancy, so that the couple is aware, like now they ask me, can we do the cord stem cell banking? So probably I want the same kind of awareness for the newborn screening, and this has to come through the obstetric obstetricians only. They can only help us in this, because patient, I have found that they are the most powerful person in this maternal child health, and patient listens to them only. Even if I say something to them, then they will go and reconfirm with their obstetrician, and then they will say, I'll come back after I talk to my doctor. So it is there, although they are already loaded with so much of work, but probably they need some education pamphlets, that suppose if they don't know what to answer, then if the patient wants that, I want information on the newborn screening, then that leaflet can be provided to the family, so that they read and they decide which includes all the costs, the timing, and the benefits. So probably the lab persons, those who are into this, they should design a leaflet, and which should be distributed to all the obstetricians, the neonatologists, and the pediatricians, so that they are comfortable when they are talking to the family about the benefits of the newborn screening. And this is the only way forward.
Thank you, madam, for such a strong and wonderful message. With this, I thank you very much for taking your time to make this presentation, and I thank all the audience to be listening to the talk patiently. And I thank the organizers to arrange this wonderful talk.
I also
Okay.
thank MedGenome for
Yeah.
giving me this opportunity to discuss about the, how to improve the newborn screening uptake for the people, those who need it. They don't have their voice, but probably we will have to come forward. So thank you, MedGenome, for giving me this opportunity.
Yeah. Thank you, madam.
Okay,
Krishna, do
bye.
you want to add anything about sharing the presentation, or do you want to conclude?
So we can conclude now. So I think we have answered all the questions from participants, and the discussion was, of course, very enriching for all of us. So
Yeah. Thank you, madam.
Thank
Thank
you.
you, Krishna.
Sir.
thank
Bye.
you, ma'am.